There we go. Hi there. I'm hoping it's working. It's supposed to be streaming. We had some questions after, everybody shut down yesterday. So I wanted to talk a little bit more about insurance and about why we're doing what we're doing. And might share my screen to show some things, maybe not. Um, but how do doctors in conventional medicine, how do they make money? So there are these fee schedules. They start with Medicare. Medicare publishes their fee schedules. And from those fee schedules, there's an unpublished discount factor, right? So patients sometimes are floored by how much a surgery cost or a lab bill is. And this goes back to Bill Clinton, I believe, was president, when they told Medicare they had to publish what they would pay. So what are you going to pay if a certain code is billed, a certain service, putting a pacemaker in or seeing the patient for hypertension? How much are you going to pay? So they published it, and then they quickly, behind the scenes, started having what was called a discount factor, which isn't published. So if I know they're paying 100 and I bill 100, I might only get 28 because there's this unpublished discount factor. So what happened very quickly is they started billing 1,000, knowing, I mean, the fee set on that initial submitted bill to the insurer, nobody ever expects that they're going to get that money. It's overinflated so that they get the maximum that's allowable after the discount factor is applied. Yes, I'm blurred. Anyways, everybody else's schedule, Aetna, Cigna, Blue Cross Blue Shield, everybody is a percentage of Medicare, right? So if you're lucky, they pay more than Medicare. Sometimes they pay less than Medicare. Sometimes they pay the same as Medicare, depending on your contract with the insurer and what you're doing. So that's part two is, you have to submit a code. And because at the tail wags the dog, at a certain point in time, and I know when this happened, Obama was president, there was a discernment by the financial people when that medicine was a business, and that you were a good doctor if you could see a lot of people and handle them really fast, and you were a bad doctor if it took you longer, And so they took away the ability back then to bill for additional time. Let's say a patient was really complex. And I'm sure at some level there was a lot of abuse going on where people were billing the high codes of spending a lot of time when they probably weren't working all those hours, because, you know, if you see three patients an hour and you're billing that you're seeing them for 45 minutes, you're going to have issues. So that's when we left Medicare. We'd already left insurance before that. That's another story. It wasn't a planned thing, but it turned out to be a good thing at the time and for a very long time. As we've gone back into trying to help more people and have people be able to utilize their health insurance with what we're doing, because I mean, I know mine just went up. I'm paying almost 1,300 a month, and I have a big deductible. you know, I break my leg, you know, walking through the parking lot or something, I now have, I have insurance covered. It's really catastrophic to me coverage, even though it's not labeled a catastrophic policy. It's a conventional United Healthcare employer offered policy, but $1,300 a month, crazy. Um, so the behind the scenes of that is when we started going back into insurance, we knew we didn't want to follow that widget phenomenon of, getting paid more based on how many you saw. And we didn't want to shortchange the care that people expected from us, which were the longer visits and the more education and the more in-depth labs. Um, Unfortunately, because of what the schedules are, share my screen. Did I close it? I don't see it. I must have closed it. May cancel. Sharing. Cancel. Go back over here. So this is one of the companies that we are contracted with. And blow it up. And now let me share my screen. There we go. So I hope you can see the fee schedule. So these all have an associated amount of time with them. So a 99215 is essentially a 40 minutes spent on the day of the appointment with the patient. Okay. So we're not a facility, so we get the higher number, I believe. I'm not the person who does the billing. So if you look at that and you say, okay, 40 minutes, I would get $102. And then where's my 20-minute code? Well, right here. I'd get, if I spent one 40-minute visit and one essentially 15, 20-minute visit, we would receive $153 and some change from our $54 and some change from the insurance. If I see 4 of these an hour, because they're really 15-minute visits, wow, I'm going to get 200 and some dollars an hour, right? If I, because of the time flexibility of it being on the day of the appointment, some of that could be, things I looked at before you came in or signed off on or something, not necessarily face-to-face time with you. Maybe I could squeeze 5 of those in an hour or 6, right? Those are for established patients. And I can even go to the 10-minute visit where I could get 6 of those. Well, the money falls off a little bit because a lot of times these are really being used for quick nursing type things. So docs primarily use these. And we can't make overhead and everything based on what the reimbursements are if we're going to spend at least 30 minutes with every patient, because this is kind of an in-between code. You can't squeeze both of those into an hour. So let me stop the share. So to be able to deliver those 1 hour and half-hour appointments and to accept what the insurance is giving, we decided to do a membership. And that membership is, I think, $3.99 for the year. And we will bill the insurance. You're still liable for what the insurance says you're liable for. So if you have a deductible, it goes against the deductible. If you have a copay, you got to pay the copay. It's considered insurance fraud, not to collect from you what the insurance says you owe. So that's why we've been doing this membership thing. Like I said, there were a bunch of questions about it afterwards. The other questions were about Medicare. Why are we not taking like Health First Medicare or Florida Blue, the Advantage plans? And they pay significantly less than Medicare pays. That's why it's hard, sometimes with those Advantage plans to find doctors who actually take the plan, who are actually in network. And I'm going to tell you that the websites that say who's in network lie, because I've been told I show up as being in network, even though I am not in the insurance world personally as a provider, but I will show up sometimes on some of the lists showing that, oh yeah, I am a network, but we're not. And we hear all the time people calling and saying, well, it said my doctors were in network, but then when I called my doctor, they don't accept the insurance. So the Advantage plans versus Medicare, straight Medicare plus a supplement cost a little more. Medicare Advantage plans cost less. The way they make money is Medicare pays them to manage your care. That's why most of them are HMOs. There are some PPOs. Doesn't really matter because a lot of people who don't take Advantage plans don't take either one, whether it's a PPO or an HMO. And some of it is spun for the consumer. Oh, you don't need a referral. Well, theoretically, the insurance company has said you don't need a referral, but the specialty office oftentimes wants a referral. So even though you could call and self-refer, a lot of times they won't take that. So the reason we're only in network right now with Cigna and not all the Cigna plans and Blue Cross Blue Shield and not all of them is in part, some of them, they don't want any more providers. They're like, our panel's full. We don't need anybody. I mentioned yesterday that Aetna has already told us no, TRICARE's already told us no. They say they have more than enough providers. They don't need any more in our community and Melbourne. They pretty much look at Brevard County as a whole, and I think TRICARE even includes Orlando in our territory. Health First, we're not even looking at really. They're one of the most poor payers in the community. People do it kind of as, you know, there are a lot of Health First insured people out there, but there's not as many as there used to be. I mean, not even Health First employees have Health First insurance anymore. So there's reasons for that. That might change as things evolve and, as Advent Health becomes more involved in their ownership or whatever it's going to be of the Health First system. But the other side of that is right now we're not even pursuing Health First because of how little they pay and how long they take to pay. And I get that from people who currently accept Health First for different things, whether it's they provide services or they're physicians in the community. So I hope that helps explain a little bit about what we're doing with insurance. It's still really confusing. Katie, our new patient coordinator, is pretty adept at explaining it. And I just want to give you her phone number while I'm here. So her phone number, her direct dial, and it will accept text too, is 321-806-7436. Thank you for watching.